That'd be good.
You started.
All right.
And you can start the meeting when you want. I'm just
Hey, Loretta.
your meeting, Donna. So
Yeah, I'll give people just like a few more minutes to come in.
Sure thing. We're right at 9:59.
Mhm.
Morning, everybody. Maretta Brown Miller here. Happy Wednesday.
The energy.
Good
Give it all to
morning.
Give it all to me.
I know, right? Loving the energy. Loving the energy.
Hey.
I walked 2.11 miles and I came down to sit at my computer to make this meeting.
Wow. Wonderful. So awesome.
Oh, cool.
I guess I could go ahead and put the
Dr. Farrell.
I guess like a couple more minutes and then we'll go ahead and get started. So did everybody on so far have a chance to take a look at the draft letter?
It's nice. Yes.
Yeah,
Nice letter,
Good.
Mama.
great.
Got
Great.
it.
We'll be sharing it here. If you haven't had a chance to look at it ahead of the meeting, we'll pull it up here so we could take a look at it. And we are open to any suggestions, edits. My hope is that it's pretty much done so we can get it out. But of course, if you have input, we're more than happy to hear it. All right. So
I want to do a special shout out. Dr. Nance,
Yes.
hello, it's Leslie.
Hi, how are you, Leslie?
I'm fine, sir. How you doing?
I'm doing good. What about yourself?
Pretty good.
That's good.
Thank
Glad
you.
glad to see you.
Yeah, same here.
all right, so I'm gonna put the agenda up here. Where's my agenda?
It's
Oh, I
also
love it.
It's also in the chat.
Okay. Can everybody see the screen?
Uh-huh.
We can.
All right, great. Wonderful. So just a quick run through of the agenda before we get started. So this time we're not going to go around and introduce everybody. I'm just going to ask people who it's their first time attending the meeting to introduce themselves. And then we'll do a quick organization check-in to see if anybody's had additional discussions with their staff or their teams at their agencies, organizations. If there's any new testing information, Leslie, I'm glad you're on the meeting today. And if any of you have had changes in your processes and procedures at your agencies. And then we'll go over the letter really quickly and then talk about scheduling a training, because education is going to be key for all of the agencies here to be able to make changes, be informed so that you can make changes in your organization. Okay, so I guess we could go ahead and get started. It's 10:03. So we're going to ask anybody who it is your first time at this meeting to give us your name, your position in the organization you're with. No new people? Everybody's been here already?
Willie
Okay.
Davis says it's his first time here.
All right. I can't see everybody here because I'm sharing my screen. Willie Davis, do you want to introduce yourself? Unmute yourself and tell us where you're from. No? Okay. That's all right with me. All right, so can we do a quick agency check-in? to tell us if there's been any changes, any great conversations that you've had, any changes to processes and procedures. I was emailing back and forth with Dr. Price over at Lawndale Christian. He also kind of heads up the program at St. Anthony's. And he said that they have been looking into getting the test strips. They were concerned though that because they haven't been able to find a place that would sell them in bulk, and it wasn't cost effective for them to buy packages of 25 or whatever. And so they're now looking into purchasing a machine so that they can do the more accurate testing in-house. He wasn't able to make the meeting today, but I did want to share that from Lawndale Christian. Anybody else have any updates of changes that they're making or conversations that they've had?
Hey, Vonna, it's Chelsea from Live for Lolly. How are you?
I'm good, Chelsea. How are you?
Can you hear me okay?
Yep. Yeah, now I can't hear you, Chelsea. Oh, I guess she was just saying hi. Okay. Anybody else?
Oh, that was, no. I'm sorry. That was so weird. My internet cut out.
Oh, okay.
I just wanted to say that, we Live for Lolly gets our fentanyl test strips from Dance Safe. They're like $1.30 per strip. So I don't know if they've looked into that, but I just wanted to mention that.
Okay, great. Thank you. I'll let them know that as well. Can you buy them in bulk though? Because I think some of the places, they limit the number that you can purchase at a time. So
I think we get them in packs of like 1,000. I mean, I think that there's a pretty large number. So if you want to connect us, I can direct him to the person on my team who leads that.
Wonderful. That would be great. We would be interested in that as well, because we have to buy them in boxes, So yeah, can you put the name of the company in the chat too, Chelsea? That'd be great.
No problem.
Thank you so much. Anybody else? Peter, what have you guys been doing over there? I know our last meeting, you said that you were doing some things over at Task.
Yeah, no, thank you. Now I think I've gotten the message clear to our staff in the community now that are working in the homes with our parents. And if anybody's seeing anything closely related to even traces of cocaine use, not even a positive cocaine test or anything in the opiate realm of things, they're just to do a fentanyl screen. And then talk, and to make sure and talk and discuss that with everybody just to see if there's an awareness. And what we've been hearing so far is nobody's the families that we're dealing with right now, mostly younger adults, late teens, early mid-20s, are totally clueless. They are not aware of it all. It's not like they're denying substance use. They're very open about their use of alcohol and a variety of other drugs. But what's interesting is we're just like, they're surprised and not aware of that even being. So we're trying to do some cautionary things about just for what you're purchasing, in the community and things of that nature. So I do know that PCP is still being purchased primarily on cigarettes. And one of the problems with that is we were talking about marketing and how fentanyl is also marketed, and with the lower cost of fentanyl, that worries me. It is a bit concerning as well. So I told staff to start opening that up to PCP screening also, because of formerly on the street names as Wiki Stick, Happy Stick, and things of that nature. But from what I understand, they're sold on the street, of course, cigarettes, because the cost is so extraordinarily high, but also in tobacco shops and little smaller stores. So, and I'm not trying to start a conspiracy or anything like that, what's happening, but I know businesses are trying to survive, but I'm trying to get people across to that just to try to get our outreach into this as quickly as possible.
Yeah, thanks, Peter. That's so interesting. I'm glad to hear you share that, because I know that we were having that experience as well. Early in these meetings, people were asking if they know that they're consuming fentanyl. And our experience has been no. You know, they would swear up and down that they were doing heroin. They weren't seeking out fentanyl. But that's what is out there. So I'm glad to hear you say you're having the same experience as well. So that's really, I guess I'm thinking too, we need education as providers, but maybe it's also kind of a campaign to educate the community, the people we
Yes.
serve, about what's out there, you know, because I know some of our guys are like, yeah, we know fentanyl, you know, people overdose over fentanyl, but I don't think they understand kind of like the magnitude of this issue and just how potent it is. And it's tricky because you don't want to tell people with substance use disorder that something is really potent because you don't want them to run out and go get it.
Yeah,
Which is
exactly,
sometimes what
exactly,
happens.
exactly. That's what you don't want.
Right.
That's what we don't want. So it's kind of tricky, you know, how do we navigate that
'Cause-
to
'cause-
educate them, but not
Yeah, because people
make
will
it
look.
attractive, right?
People will look for it if they feel like it's going to get them high or get them to where they need to go.
Exactly.
Yeah, I saw that same thing about 15, 16 years ago when we were first starting to see fentanyl in the Chicago metro area.
Right.
Actually, people were really mystified. Oh, it's the guy, you know, that was the
Oh,
spot
it's the
everybody
good
went
stuff.
to, for goodness sakes. And not even thinking about the risk factor of
Right.
overdose.
People looking for
I
the
did want
bomb.
to share something kind of on topic and directly to this. Recently, one of the super licensed programs is closing in a matter of days, if not weeks. The Women's Treatment Center, which had residential programming, if it hasn't been around yet, and one of the critical services they provided, aside from anywhere from 40 to 80 residential beds for females, also with moms bringing their children into care, you know, into residential treatment. They also had a medication assisted program, outpatient, also level 1 and level 2 outpatient programs, as well as a medical detox. So, and they never shied away or turned people away.
Right.
So that program, it no longer exists now, which is really scary because
It's
there's no
so
way that programs can absorb that, you know, those service needs right now in the Chicago metro area.
Yeah.
So
Well, I'm sorry. I'm sorry, Peter, go ahead. No, I
no,
was,
that's fine.
I thought you were done.
Questions. This is something that's brand new. We just found out on May 5th, our agency, because we work in a contract with one of the contracted agencies with the Women's Treatment Center. But at Central Intake, that program is gone and they stopped providing those physicals last year during the pandemic, and the contract now ceases. That doesn't exist anymore. So all of their staff are scrambling around for jobs, of course. So it's super right now, as far as I know, is in the planning stages, but this didn't follow the 90 days or 6 months notification that occurs when an agency of this scope and size closes. So needless to say, it's devastating. From what I understand, the Mary Thompson Hospital building was already sold. So another community in another area gentrified, of course. So we don't know if it's townhomes or condominiums or what's going to be in that building. But it's very sad because, again, we lost another vital treatment cog on the west side of the city of Chicago that you can't fix that or replace that overnight or anytime soon. And that also is very concerning for all of us at Task as well.
Yeah. Thank you, Peter.
just gonna say, their MAT program, they had about 400 or 500 clients. It was really easy to build up their clients because Central Intake is such a crucial part of the drug subculture out there that's been going on since I started in the field. At one point I ran Central Intake or was the administrator and the Women's Treatment. But anyway, it's very sad. And so if any of you MAT, I'd call Super and say, hey, we're open to referrals, or if you need any help or support with the clients getting placed, it would be a good reach out, because I know the Women's Treatment Center wants to do good. I think they're going to close their doors June 1st. So any day now here. So, wow.
Yeah. Dr. Sorrell, see you had your hand up. Go ahead.
Yeah, guys, I don't know if this is Providence, but I literally just got an email from someone at the Chicago Tribune who's seeking an interview about closing the Women's Treatment Center.
Literally just got the same email, Dr. Sorrell.
Okay. So I know I'm not as detailed on what the events as some of you guys, but it sounds like this is an excellent opportunity to be able to get the word out and what you were just saying, Peter. I did post the information. I checked with Catholic Charities. They are able to take some of these women, and they do have housing and other services available. The clients do need to live within the West Side area because the contract for Catholic Charities is only for the West Side, so that is a limiting factor. I believe someone else posted something in one of the meetings on Monday, but I think that was for services in Rockford, which unfortunately is another barrier. But we certainly need to look at following up with this John Kyleman about the Chicago Tribune. I think that's an excellent way of trying to get the word out that there's an issue happening here.
Yeah. Okay, great. Thank you, everybody.
One thing that I did hear from patients was that because we're trying to absorb some at Miles Square with family guidance, because we have the methadone and buprenorphine here, is that the line to switch care is pretty long. And so I think reaching out to them and seeing if you can be on site to help patients sign up will be hugely beneficial, because then the patients can choose which organization they can transfer their care to. So if you're interested, I would reach out to them and see if you can, be on site for their dosing hours. And for those of you who do methadone or the other, programs that you may have, because there was I know Family Guidance had sent a person there, but there was a pretty long line from what I heard.
Thank you.
The contact, the contact person at the Women's Treatment Center, at least would be Gwen Reese. Many of you might know her. I can put her phone number, her cell phone number in the chat if you'd like.
But I do know they're trying really hard to get everyone, placed, and it does take a little bit of time. And then there's all the additional considerations, making sure that they stay on the same, that you honor their same dose and code schedule. And, all of those factors are part of it too.
All right, great. Thank you, everybody. So we're going to move on to the letter. And let me share my screen here. All right. So there may be a few of you who have not had a chance to read the letter prior to the meeting. I'm going to put it up here and maybe you can kind of scan through it. Those of you who have had a chance to review the letter, I'd be interested to hear your thoughts. Any input about changes or edits? Anyone?
Well,
No?
my initial, this is Richard at the Salvation Army. My initial thoughts regarding the letter was I agree. I mean, there's a lot of, we've had clients that have come through our program and they've tested positive because the opioid with fentanyl, it stays in their system longer. Even if they go to detox, we've had individuals that we were turning away initially because they would come straight from detox and come to our facility and they still have, they still test positive because it's staying in the system longer. So we've had that situation. We've been kind of trying to reconcile on how to manage that. And then also we started our medication assisted treatment program here at the Salvation Army. We're trying to kind of work our way around this issue as well.
Yeah, great. So is there anything in the that you think we should have included in the letter that it's not in here? Information that it would be helpful for Director Jones to know.
I would say the other thing to think about is, so I did contact SAMHSA because some of the programs use urine drug testing right as a way to for some of their federal admission criteria to meet the fact that they have a diagnosis of opioid use disorder, because that's an easy way to say that they do, right? So they use that as part of their, intake protocols, but I don't think there's enough education depending, it's not necessarily the organization, but those who are doing the intakes may not have the education, or the protocols aren't written in a way where they then realize that opioid use disorder is you use the DSM-5, right? You don't use a urine drug test or any drug test really to identify. You can identify someone with opioid use disorder with physical exam findings, history, all of these things that will allow you to meet those federal regulations. So I think coming up with an educational, like you just said, lack of fentanyl education for providers. I would definitely expand on that because that can be really helpful, because I don't think some agencies train their staff, or the agencies themselves have written the protocols in a way that says, like, if you do not test positive, we will not admit you to our program. Right. Which doesn't make any sense, because that's not how you diagnose opioid use disorder. So I think highlighting that is exactly like Peter wrote, treat the patient, not the urine test. We have to do a better job as a system, as clinicians, in appropriately diagnosing someone, which again, you can get from history, physical exam findings. You do not need a drug test in order to do that.
Yeah. I do know that my experience has been, you do have to, what proof of diagnosis, right? And so what is that proof according to Super? For us, it's at some point, either a clinician has diagnosed them with opioid use disorder or substance use disorder, or a positive test from when they came into the detox or treatment center, wherever they were. So maybe that should be part of the guidance by Super. How do we handle the situations where we are not testing?
Maybe situations like, for example, like we're running into this problem here. Sorry, I don't mean to talk so much. I'll stop after this, but
no, it's okay.
Finding a CLIA waived test that our organization will allow. For fentanyl, I haven't been able to find a CLIA waived test, a CLIA waived instant test. There are the strips that you can buy, but they're not CLIA waived, so they're not approved by the university to use in medical management. And so so organizations may, when we do fentanyl testing, we have to do it as a send out, and that can take up to 7 days to return, right? So I think highlighting the fact that you should use what you have available and what your organization will allow you to do, but then also recognizing that the confirmation of opioid use can be done through physical exam, patient report, and patient report.
Okay, that's a great point. Thank you. Anyone else have any feedback on the letter?
I think the letter is really good as a starting point. I think it's excellent, Juana. In terms of the fentanyl issue, I'd have to agree with Nikki on everything you said, Nikki. However, there are confirmation tests and companies that can turn around a confirmation test in 24 to 48 hours. And so, we could, and I'm not honestly, Ammon or any of them, if they're doing, and again, we can talk about it when we're on the agenda, but the strips, which give you a real good insight, is not going to pick up all the fentanyl. There's like 23 to 24 analogs, and they change all the time. And so the strips only pick up one, maybe two of the analogs. Okay. So but I think the only way we're going to tackle this, besides what we're doing now, is education, so that when policies are made, it's grounded in factual information. Like, I forget who was talking, that's from the Salvation Army, that said fentanyl stays in your system longer. I'm going to come back. I'm going to go back, because I'm not the scientist. I'm not a lab expert. I'm going to verify that from a scientist to see, does fentanyl stay in your system longer? That was the first time I heard that. I'm not saying you're not right, but we don't know. Okay, so I think, let's do the best to get the facts, and then educate on the facts. You know what I mean? It's not like who's right, who's wrong. There's so much different information out there that it's difficult to channel through. So that's my commitment to the group, is to check some of this stuff, so everybody can make.
There's a toxicologist at Rush and a toxicologist at County. That's who I would reach out to about that. They're going to know how long it's in the body, what tests you can use, what are hospital approved, what are not, especially if you're talking about admitting someone like at St. Anthony's, or just for example, another like withdrawal and stabilization program. They may have different policies on which type they need. They may have contracts with certain companies. So I would ask a toxicologist, and they'll be able to get you that information.
Oh, thank you. And that's what I was going to do. But yeah, I'm not sure County does all the confirmation testing on fentanyl right now. You know what I mean? So we've got systems. So anyway, I'll do what I can. You guys do what you can, and we'll come back together and flesh it out. That's all we can do at this point, and get some training.
Yeah. So, we've had that experience too, that we saw that people were, they go to medical stabilization programs for 3 days, come back and still test positive for fentanyl.
Okay.
But there has been no official guidance that says it stays in your system past, a certain amount of time. And so we have to go with what we already know, which for us, it kind of, our internal conversations was that Super would give us that guidance. They have all the resources and to do the research and find out about all of this. And I think that would be part of the guidance, to allow people to use their budgets to buy the more accurate test, or send them out for testing, and then give us some more information, find the data, the research, whatever it is that we need to be able to provide us as agencies as providers with guidance. So that's part of here too. And we're not going to tell them how to give us guidance. I want to allow them to decide, but we need guidance and support around this. All right. So other than, go ahead. Was somebody
I
going?
think we could tell them how, if we have the right answer, or what our recommendations are.
Well, I think I don't want to make it too, because my goal is to get this out, right? And if we are waiting to do, how would we ask them to provide guidance for us, right? To me, this is the first step.
Right.
Get the letter out to Director Jones, and then maybe invite him to have a conversation with us about it. And then we can get into the weeds a little bit.
Yeah, I think we need to kind of establish this group as the go-to group on the west side to have that conversation. If there's some outliers, that we ask them to join us and be a part of this as well. Not to cut them out of it, but please let's use this as the vehicle.
Absolutely.
Because it's well established now.
Yeah. So what are you guys' thoughts about having this be the starter for a conversation? This can be the start of the conversation with Super.
Love it.
Okay. All right. So yeah, I want to make sure we're ready to go on this. Okay. So what I'll do, go ahead.
Can I ask a kind of a dumb question?
No dumb questions.
I doubt it's dumb, John. Yeah.
Thanks, everybody. Thank you for the confidence. So I'm just not that well versed in like the diagnosis process of substance use disorder, and something is just sticking in my head. Are drug tests used as a primary way to diagnose people with substance use disorder, or because those are, in my head, very two different things? Like positive drug tests, substance use disorder are very different.
Well, what happens is that a lot of times that's the first step. So somebody goes to detox, they're gonna test them when they come into detox. If they don't test positive, they're not seen by a clinician, right? So they can't assess them to give them a diagnosis. So that's a
Kind of
barrier.
weird.
And John, it's Chelsea. You know, in my private practice, when I'm working with folks who are struggling with substance use issues, you know, we're basing, like, kind of like Nikki was saying, we're basing the diagnosis off of the DSM-5, which doesn't include information about whether or not that person is actively currently on drugs. It's about more of the impacts and the patterns and the cycles of behavior around drug use and the impacts that's had on somebody's life on a severity scale. And so that's the way that we view it. And so I just want to throw that in there, because aside from the medical piece, there's still the clinical social work piece, that this is how we do it.
Yeah, so other people here that work for facilities that have detox or treatment programs, is that accurate? I know from a recovery home standpoint, that's what happens with our residents. They go to detox. They get tested first. If they're not positive, they get turned away. If they are positive, then they go on to the treatment center. The treatment center tests them, you know, but they have the diagnosis from the detox, because if they're positive, they get to see a clinician and then, you know, get assessed. So typically the first step is a test. Correct me if I'm wrong, because I'm not a clinician and I don't work at a treatment center or detox.
I think that's
Oh, you got it right.
yeah, you have it right. And I think that's the problem, because that's not the best. That's maybe the most easiest way based off of what staffing is available and how an agency develops their workflows. But the actual best and standard of practice, and I'll put a few papers in the chat. ASAM published this really great white paper on drug testing and when you use it and how you use it. And it's really to aid your clinical decision making and aid the care of the patient and aid their recovery and discussion and all of these things. It's not to be used for diagnostic, because one, the drug trade changes so much, our testing is not going to catch all of the things. Two, it tests a very specific substance within a specific time frame, right? And that does, or the absence or presence or absence of a chemical in a person from a certain period of time. That is not anywhere within the diagnostic criteria. And we, you know, standard of care is that we use DSM-5 to diagnose someone with opioid use disorder, which can be done by licensed, you know, social workers, psychologists, you know, docs, NPs, PAs, but the diagnostic criteria for opioid use disorder is based off of that, not based off of drug testing. That's a really good question, John. I'll put that in.
And I really appreciate everybody's clarification. Thank you.
You're welcome.
Well, just to add on this, how how drug testing has evolved as the barrier, or, you know what I mean? And also how many folks we've sent to jail with a positive drug screen, even though they might have, you know, slipped a little bit. You know what I'm saying? And like, we've used it as a weapon, and that's how it's evolved in the field. And that's not the intent. I actually thank you for sharing about the ASAM guidelines. We should probably either include that maybe, or read it, for all of us to read it first, and then include it in the attachment to the director, or at least have it on the agenda as a briefing tool before we meet with him, you know, because that's kind of we're all saying SAMHSA, and I know SAMHSA is great and they do all these things, but you know, SAMHSA is struggling too right now to figure out what to do with all of the issues. And so to have ASAM, the docs, with an official position, I think is really powerful.
All right, great. Thank you all. All right, so on the following agencies support this effort piece, what I would love to do is to include all of the agencies that have taken part and the individuals who have taken part in this, been involved with the work group, have the organization's name and then a signature line for you guys to sign off on, or at least a name. because we may not be able to physically get all of the signatures, although we could. If I put it in a PDF, you could do an electronic signature. So that's what I would like to do. If you want to support the effort and put your agency's name or your name on the letter, I guess you could include it in the chat. I think maybe that would be the best way. Just include it in the chat and say I'll sign. So we'll have a record of it.
Do you want, okay, I'm sorry.
Go ahead, Lee.
You want to have a drop deadline? No, bad term, but you have a date that you want this in?
Yes, I think we can get it done by the 31st. I'd like to send it out in the beginning of June 1st, 2nd, first week of June.
So if anybody needs to go back and reach out to their quote superiors or, you know, other folks in the field.
Mm-hmm. Yeah, I think the 31st is a good deadline. If we need more time, if somebody emails you or I and say we need more time to talk to our team or whatever, we can do that. But I'd like to shoot for the 31st. Peter, did you have your hand up?
Yes, I did. I also have a PDF. I thank you also for sharing that other information from ASAM. I've got the PDF. It's titled Public Policy Statement on the Ethical Use of Drug Testing in the Practice of Addiction Medicine. It's a 4-page PDF. So I'm going to put my email there. If somebody wants to send me an email, and I'll be more than happy to to reply with that as an attachment. It came out, it's public, it's wonderful to use. ASAM is really promoting that because, as Peter had said earlier, we're not supposed to treat the test, and I mean, the American Society of Addiction Medicine is, is trying to get away from that, for goodness sake. So thank goodness we're all getting more closer to being on the same page with the ethics and everything. So, but please send me an email and I'll attach that back to anybody who sends me an email this morning.
Okay, thank you. So a question for the group. Now, I totally agree with everybody. The test should not be a barrier to treatment for anyone, right? And the ASAM document you're talking about, that's wonderful. But we're asking in this letter to allow us to test for fentanyl. So I don't know that we should include something that says we shouldn't be using a test. Do you know what I mean?
Well, we could say something like fully understanding that no diagnosis should be made on tests alone. We still nevertheless. So we
can add something
to
like
that point
that
we're totally aware of this, but this is also a tool we need.
Assessment. Yeah.
Yeah.
A thorough clinical assessment is necessary for each case to appropriately diagnose a substance use disorder.
I like that. Yes, we can add that. Yeah, I will add that and send this back out to everyone. And then I think we are good. Are people putting in, I can't see the chat right now. Are you guys putting in, those of you who are able to say now that you would sign your support to the letter? Are you putting that in the chat?
There's folks, Dr. Nance, Leslie.
Wonderful. Wonderful.
Thank you.
Great. Thanks so much. All right. So now on to, let me stop share and pull the agenda back up. On to the education part of this. All right. So we had been, this conversation initially started with Lee, Leslie, and I around training, education piece for fentanyl. And then we kind of said, no, we probably should have an open forum first to see what everybody's experiences have been and how they're dealing with this issue. And it turned into this work group. So we put the workshop or the training on the back burner. But Leslie works with, Leslie, you want to talk a little bit about the person you connected us with to do the training?
Okay, and she's on leave right now, but yes, we suggested a training And I'm gonna have to talk to Vaughn and Lee offline about that, and I still want to do it, but there's some other things that came up. I'm not,
Okay.
that are out of my control. I'm a consultant for Ammon. So,
Mhm.
what I did was, first, I'm sorry, guys, I'm trying to find the document, but I did get some correspondence from the, what's it called? There's an association that, here, wait, Center for Forensic Science Research and Education. It's at the Frederick Ryder's Family Foundation, and they get support and funding from the National Institute of Justice. And they submit they do put together quarterly reports to look at the trends in the you know, like the fentanyl type drugs that you could buy that are legally, that aren't necessarily illegal yet, but they're of abuse. And so I sent that report, and that's the quarter one from 2021. I sent it to Lee and Vonna, and we were going to talk about it, I think, before we presented it to everybody and get some information, some additional information. But it's kind of a guideline to testing labs and to bigger providers of what are the drugs what are the things that really do need a confirmation test. And this is totally objective information. All right. So I'm not prepared to talk in depth about it. I thought we were going to talk offline a little bit. I can brief you or get someone on the phone to brief that knows more about it. So I'm the type of person, I'm not going to talk about something as an expert if I'm not an expert in it. I just, you know, it's my ethical thing. I could say, you know, and I don't want to be a sales, you know, I don't want to come across as a sales because that's not where I'm at. But, you know, I saw this document. I thought it's worth researching, especially whereas Peter, you know, you guys are doing all of this research nationally and looking up stuff. So I thought this was be another good document and another objective party that's tied to the Department of Justice. Whether that's good or bad, I don't know. But it is credible, and it gets sent out to all of this. And we got it through the state police. So the state police are into the fentanyl issue too. And some of these, what are they? Some of these drugs. So I don't know if that's helpful right now. I'm sorry.
No, Leslie, yeah, that's fine. I was actually hoping you would talk a little bit about what our plans were. I know the doctor's on doing something else right now, but our plans to have a workshop that's centered around all the different analogs out there,
right,
and the different types of tests. That's what I wanted you to speak more to, what we planned initially.
Okay.
And so maybe moving forward, that would be the plan again. I really liked what we were planning on doing then, and then the doctor was unavailable. So
I agree, and I'll get back to you right away on that. Okay.
Okay. All right.
It has to happen. What?
Let me ask if we need to have a contingency plan, and I'm not sure if Dr. Costello is still on, but or anybody, do we have some experts within our reach in Illinois that could fill the gap if there's a time lag between you know, the Ammon's person and whatever? I mean, you know, what's our, you know, what would be a incremental step here, or if not a full step into this with some expertise that we have within our own purvey here?
Yeah, so I guess that's what we need, someone who is an expert on fentanyl and the analogs and testing. That would be great. It could be somebody local, it could be somebody in another state who maybe could do a virtual workshop. For us, it doesn't matter, but I think training or education around this issue is important, and that we need to do it fairly quickly.
Right.
And
also
what that
might
will
be,
look like.
I was thinking when Leslie was speaking that we may be able to, I don't know where it would be housed, but a resource called library, that we could kind of have some place where new and current information for whatever level people want to dive into it, that would be available. you know, that's something we could also think about as well moving forward. So there's always some fresh information that, and a place where people can go to kind of check in.
Yeah, I would be happy to help with the education and pooling some other clinicians together around the state who have, you know, expertise in this area. Another place that might be a good place to house it is on the helpline too, because there's going to be a provider section on the Illinois helpline. So that way they would be able to, and then we could make sure that it gets updated, you know, regularly, at least yearly, because we're trying to find a place, right, for providers and patients to have sort of that one resource. So that might be a good place to do it. What would be the sort of venue that you would want? Would you want a town hall? Would you want just for the task force? What are your sort of thoughts? And then I can, you know, reach out and start working on that part. And Tanya, I'll pull her into.
Right.
Yeah,
That was-
I'd like to have the opportunity to follow up to see if Dr. Marzelli is on board, like she said. I mean, and if not, and she might have a you know, whatever is happening with her is beyond all of our control. So, but she's a wonderful person and she's bright and she's on the national circuit for this type of training. So if I may, I'd like to have first shot to see if that's a go within the next day or two. And maybe we set something up where she speaks and somebody else speaks. It doesn't have to be all her. We could set up a panel, you know, however we want to do it, we should do it.
That's exactly what I was thinking. It can be more than one person, right? And maybe, yeah, absolutely.
And to your question, Nikki, about, I mean, whether it's the task force, the focus should really be on our providers on the west side. I mean, I think that, you know, we don't want to dilute it too far. I think it probably has some spread. If we ever taped it, we could then have something that other folks could share. But I really, this was a unique group that came out of a concern on our front door. And so I think that would be great. And that would make sure that we're honing in on where our concerns are.
Right.
I agree 100%. Yeah. And so we can start there. Who knows where this will go, right? And it could be more than one training. It could be a series of trainings. And
Yes.
depending on how those go, then we may be able to open it up, but we do need to start here. And I think it's important to have somebody who knows our environment too. What it's like on the west side, what drugs are coming in our area.
That reason, Vonna, as a training facilitator, I'd certainly love to throw my hat in the ring, because the sensitivity and making sure that you communicate this sensitive information accurately is going to be critical. So I'd love to throw my hat in the ring.
Wonderful. Wonderful. Thank you.
I think also, Vonna, with the leadership center development of our agency partners on the west side. I mean, like the last few weeks, Rush has been able to kind of go out and actually meet people and meet some of the west side agencies. And as part of the regional leadership center that Super is developing for Region 1 and 2, I'm happy to help with that discussion and coordination so that we're really getting informed from the actual providers and the actual neighborhoods and clients what's happening and how we need to have that built out.
Absolutely. Yeah.
Each method for this.
Wonderful. Okay. So we're moving right along here.
Yeah, I mean, this is truly is a advocacy community, starting at the community level. I mean, it's really cool, you guys. I mean, I know I don't live on the west side right now, but I spent so many years working on the west side. My offices were on the west side, you know, so it's like, I don't know, this is where my heart is, you know, I might do other things, but this is my heart. So it's really cool to hear.
Awesome. Wonderful. So you guys can, if you, the people who agreed to throw their hat in the ring for the training here, wonderful, yay. If you have other people that you want to suggest or connect us with, you can email both Lee and myself, and our next meeting. I'm gonna get this letter out to you guys before our next meeting. So plan our next meeting, and we'll send a notice out of when it'll be. It'll be Wednesday and a Wednesday, 10 o'clock. But then we'll be ready to start talking more about this training. Does that sound good to everybody for next steps?
Yes, I have a question. Is Randy Weber still around for you old timers? Randy Weber was the Illinois, Chicago. He started out at Chestnut, but in Chicago, and he's like the guru of pharmacology, or has been all these years. So I'm gonna
I see a Facebook, people you should know on Facebook.
Is it?
Anyway, but it wasn't a request, so I didn't do anything.
I don't know. I've been a while. But he's the guru. Randy said. So I wonder where Randy went. Where's Waldo? Right?
Leslie, he still has a newsletter that he uses that comes weekly, and it typically arrives on Tuesdays or Wednesdays. So yeah, he is still doing that, I know. And he was working out of an office, I think it was in Evanston, but where specifically he's located, I'm not sure.
All right, I'll follow up. I'll check. Thank you, Peter, and everyone.
Yeah. Dr. Nance asked the question in the chat when the training will be. We don't have a date yet, Dr. Nance. That's what we'll discuss at the next meeting. We need to identify we need to discuss how we're going to do it. Are we going to do a panel, which I think is a great idea? Who's going to be a part of it, and choose a date and kind of the topics that we all need training on. Fentanyl, big umbrella, whatever you can tell us about it, and testing, right? All right, you guys, great meeting. This work group is awesome because I feel like every meeting we're getting stuff done. We're not just talking. So we're making progress. It's wonderful. Thank you all so much for your support. You'll get an email with Lee with the revisions that you suggested to the letter. And then I'll convert it to a PDF and send it off to everybody for electronic signatures. I think that'll be the easiest way. Okay.
Dr. Nance had his hand up.
Yes. Can I invite someone? I would like to invite Dora Danzler, right?
Absolutely. Absolutely.
Yep. She
knows a lot about fentanyl.
This call for the meeting, this announcement for the meeting goes out to the 500 plus people are on our email list.
Okay.
And I know John has been on, but reach out to the folks that you think need to be a part of this. And let me just put a plug in. If you see other topics that you think have spread for other folks on the west side, we can put work groups or have at least a confab together around certain topics that you want to bring to people's attention, see if they resonate, and then we could do work groups on that. I mean, again, we have a 500-person email list. We have the ability to kind of go where the task force needs to be going. So continue to pull these ideas together, bring them forward, just like Juana did, and we'll try to make sure that we have a voice or get an opportunity to get them out. So I see Dr. Sorrell has her hand up.
I'm sorry, just one more question. Does anybody have a wholesale phone card company that you're using to buy phone cards for your clients for tele appointments? We've got a little bit of money that we'd like to spend in a good way to be able to give some phone cards for minutes for our clients so that they can do their telemed appointments. Okay, so sounds
as
like
the crowd goes silent, right?
No problem. When I find the company, I'll post it to everybody. So it sounds like once again, when I mention it and it ends up something that I'm doing, but it's okay.
Yeah, Dr. Sorrell, what we've done at Phoenix for that is that we have loaner phones that we have them sign out and use the phone for their telehealth appointments. And then they sign it back in when they're done.
Do you find that works better?
It does. It does. And they're really good about it.
That might be less problematic, because then of course you want to always have to justify, are the minutes going to telemed appointments and all that good stuff.
Exactly.
So, okay, great.
Yep.
I knew you guys would know. Thank you so much.
All right. Thank you guys. And you'll be getting an email from us shortly. Appreciate you all.
Thank you, Vonna, for leading.
You're
for
welcome. Thank
such
you,
a
Leslie.
Wonderful leader. All right, bye, you guys.
Hey, Moretti, you did a
Bye.
great
Everybody have
job
a
the
great
other
one.
night. You did a great job on Reverend Jones's event.
Oh, thank you, Mr. Lee. Thank you so much. I'm working on trying to do better.
Well, you're already there. You're already there.
Happy Memorial Day weekend, everybody. Love
Happy
you guys.
Memorial
Be
Day. You guys
safe.
stay safe.
Yeah,
Donna, this
thank
was
you.
an absolutely amazing meeting. Thank
It
you all.
was.
Right.
It was.
Thank
It
you
was
so
very-
much.
Yeah, it was
Great.
fun. It was so
Teamwork.
informative.
Wonderful.
Bye, guys.
Yay.
It's some
Hey,
vitamin
West
D.
Side. Let's show them how it's done, you guys. Okay.
That's right.
yeah.
That's right. Make it happen. Making it happen on the West Side.